behalf of all participants, and I would like to thanks to all speakers here, eminent speakers, Dr. Carlos Matthew, Dr. Pramod, Dr. Ayman Midanat, and Dr. Patricio, Dr. Karina, for their accepting our invitation and to be with us. And I hope that the participants will enjoy this meeting as we are having a very interesting cases. It's my pleasure to, first of all, to introduce my dear friends, Dr. Carlos Matthew, to present his case. Dr. Carlos, I think if I want to say something about him, everybody know him. He's a well-known figure in vitreoretinal surgeon worldwide, and he's a consultant, founder of member of IMO, Faculty Medicine of the Autonomous University, Barcelona, Spain. It is my honor and pleasure to be with us, Dr. Carlos. Maybe this is the third time, but all the time I feel, all the time you are presenting something new that we can learn from you.
Thank you. And congratulations for the organization of all of these webinars. I share my screen now. Okay, my presentation is about a question more than an answer. You know, it's about massive subretinal hemorrhage in age-related macular degeneration. As you know, in this massive subretinal hemorrhage, the hemorrhage, damage the photoreceptors is mediated by iron toxicity, interference with nutrition flux between photoreceptors and RPE, contraction of the fibrin meshwork, and the growth of this carrying process of the choroidal neovascularization. You can classify these subretinal hemorrhages in three points. Size, can be a small, 1 to 4 these diameters, medium size, at least 4 these diameters, but not extending beyond the temporal case. Massive, extending beyond the temporal case. You can classify by thickness, measuring between the RPE and the retina, and location. And for me, this is the most important thing, mainly subretinal in the foveal and perifoveal area, or, mainly sub-RPE in the foveal and perifoveal area. And this is the two difference. In the left, you can see an eye with a, subretinal hemorrhage, that the hemorrhage is mainly subretinal, but in your right, it's mainly sub-RPE. Let me show you. In this case, only with injection, you can have, a wonderful, evolution. You can arrive, like this case, 8 anti-VEGF injections and Eylea injections, you arrive to 24 and is maintained more or less stable. But in some cases, you have more hemorrhage, and then we decide to inject some air and RTPA in the vitreous cavity or gas, and then you put the patient face down, and you continue to have these anti-VEGF injections, preserving the vitreous as a storage for the anti-VEGF. But in some cases, look at this, the hemorrhage is, larger, this is thicker than before. And in these cases, for example, this is mainly subretinal. As you can see here in this case, you have the right eye with a scar, left eye with a massive subretinal hemorrhage, but mainly in the subretinal space. In these cases, this case was in 2011 or something like this. Look at the OCT, you can decide where the RP is, then you decide that this is more subretinal. In these cases, it's very useful to do vitrectomy, as in this case, we remove the posterior hyaloid, and then we're going to go in the subretinal space, we are going to inject RTPA and fluid in the subretinal space, and fluid exchange, as you can see here. And look at this, visual acuity after surgery was 20/40, and after many years, this patient is maintained a vision of 20/25 or something like this. Look at the OCT and geography. You see the membrane, arterial membrane, but maintaining a good vision. The other side is when the membrane, the hemorrhage is under RPE. This is totally different. Look at this case, the right eye previously affected, left eye with a massive vitreous and subretinal hemorrhage. Then I injected the same. I did the same. I used the technique of Tamer Mahmoud from US. He was injecting RTPA and air, trying to move more the blood to the inferior parts of the retina. And then I did it. Unfortunately, when I do that, the air in the subretinal space goes to the 12, goes to the, the subretinal space in the upper part of the retina. But anyway, I was able to remove, important part of the subretinal hemorrhage, but not the hemorrhage under the RP. Look at this is the gas under the retina. This is the aspect 2 weeks later. And you can see here how the scar is evolving, and I didn't change anything. At the end, 2 years later, the patient developed another hemorrhage, not in the center, and the visual acuity was the same than the other eye. What other options you have? Many years ago, 18 years ago, we have the removal. In this case, we remove the sub-RPE hemorrhage and the complex. At the end, patient improve a little bit vision, but not reading. The most important thing for these patients is reading vision. We changed, and then we did macular translocation at that time, 360 degrees retinotomies, and some of these patients achieved, a good visual acuity, 0.2, 0.3 vision, increasing the, reading ability. But, complication in the macular translocation was not, so simple to perform. You have retinal detachments, PBR, recurrence, macrocystic macular edema, and atrophy. For example, this is one case I operated because only one eye, and this is 2 years later with silicone oil in the eye. This patient improved his acuity, was 0.1 only, 2200, but it's compared to only light perception. I think this is, some kind of improvement. Or this eye, have movements after macular translocation in the upper part, as you can see here. The problem with this case is that you have to move the retina a lot because the membrane is so big. Look at this. This is the aspect, the last picture I took. The patient developed also atrophy in the area where I put the fovea. Then my question to you is, what are you going to do in this case? Look at this massive subretinal. This is 2 years ago. I had this case. The other eye previously affected. The hemorrhage was mainly in the subretinal, in the sub-RP space. Then this is the surgery I decided. This is a surgery of RPE transplantation. This is an option for these kind of eyes because the surgery is composed, but we do the vitrectomy. Then we detach the retina, as you can see here. We attach the retina, making an infusion in the subretinal space. Then we are going to cut the retina in 180 degrees. We have to flip over the retina, as you can see here now. Some surgeons prefer to cut the retina with the scissors. We cut the retina with the vitrectomy tip. I think it's with the, these smaller gauge vitrectomy tips. You could do pretty well. Then, as you can see, when you move this, all the blood comes in the vitreous cavity. This is terrible. You spend, 15 to 20 minutes with seeing anything. Look at this, the atrophy, when you remove everything, you remove the membrane, and then we're going to perform the patch of the choroid and the RPE. We're performing first laser around the graft. Then we're going to perform, diathermy, and then we are going to cut just to perform this small graft to be transplanted in the foveal area. It's not that easy to know where the fovea is going to be, but the most important thing is don't elevate the tissue. Don't elevate the tissue, because if you elevate the tissue, it rolls, and this is terrible. Then, you put it there, and then the trick is to begin to inject perfluorocarbon liquid in the vitreous cavity and to remove the perfluorocarbon liquid in the subretinal space. This is somewhat tricky, but at the end, we're going to stretch the retina to the temporal side and injecting more and more perfluorocarbon liquid. We are going to put the retina, as you will see now, the retina in its place with the laser. And this is the aspect. This is some weeks later, and this is the final aspect 1 year later. Visual acuity went from hand movements to 20/125. Reading, difficult, was not a good reading. The patient didn't say it's a perfect reading. In the last case, to show you that this is not that easy. This is a case, this is the case, the other eye previously affected. And look at this, again, this is a sub-RPE hemorrhage mainly, and then we detach the retina with a 41 gauge cannula. We detach all the retinal fluid exchange to make all of this fluid to detach the posterior pole and trying to detach the clot from the retina. As you can see, the clot remain attached to the retina, and then we cut the retina as peripheral as possible in the ora serrata. We flip over, the retina, and then you will see the clot now, that this remains attached to the photoreceptor in very gentle maneuvers. We remove this clot from the center, as you can see here. Then we are going to grasp this clot with the Viteotome tip, and then with the forceps, we are going to remove it from the subretinal space, and we are going to eat all of this blood, clot blood, and do the same. We do as you can see here, we do the RP graft, and then we put it under the place where the fovea has to be, because you don't see it, you don't see the yellow color, and then we have to remove the perfluorocarbon liquid under the retina and to inject perfluorocarbon liquid over the retina. At the end, in this case, the visual result was not that good. As you will see now, the graph is a little bit, folded, and the visual acuity was not that good. At the end, visual acuity was 0.1, a little bit better, but again, the patient could not read. Then my question to you is, what to do in these cases? You have all of these options, and the question is for you, what to do in these cases?
Thank you very much, Dr. Carlos. Very interesting cases. You have mentioned several cases, not only one. So I will leave this one for Dr. Ayman and Dr. Pramod, Dr. Patricio. Anyone to ask or opinion for Dr. Carlos? You have any question or comment, Dr. Pramod? Dr. Ayman, if he is there?
Actually, I would say excellent surgical video and very, very clear demonstration of how RP transplant can be done. I think elegantly showed, really impressive. And I think I personally do not do, or rather hardly I did any RP transplant. Somehow I do not believe in that, because what Dr. Carlos has shown, the results are generally are disappointing. It's a heroic surgery, prolonged surgery, and a huge amount of risk of PVR, prolonged surgery. And when you look at ultimately, eventually, final outcome, probably not gratifying. So personally, I mean, I did subretinal scar removal, everything we tried, and after some time you just give up. You realize that outcome may not be that gratifying, so I stopped doing this type of surgeries. Now I just accept it's a large scar involving retina and RP, and I just try to counsel patient. We try other modes of visual rehabilitation, and that's what my take on this. But yes, earlier cases what he has shown were only subretinal heme. We try first only pneumatic retinopexy. If that does not work, and if you have a larger clot, probably yes, subretinal TPA. And now we have a results available with or without TPA and surgery. Even you can have pneumatic displacement, final outcome probably more or less same.
My question to you is, when you have this huge hemorrhage, imagine a patient that has only one eye.
Yeah, I agree.
And 2 weeks ago, this patient was reading. And at the end, this subretinal hemorrhage and sub-RPE hemorrhage goes to the vitreous, Then you cannot see the retina.
I agree.
And the patient at the end can end in light perception, even in no light perception.
I agree.
Understand that you cannot expect a, impressive result. But, maybe try.
I agree with you totally. But what happened if it's a subretinal? Probably I would make an attempt. That's why the differentiation is more important. I feel whether it's subretinal or sub-RP. Subretinal, definitely I would give a chance. This hemorrhages typically you see in a PCV, polypoidal choroidal vasculopathy. That's a typically scenario we are dealing with. So, but sub-RP, generally they do not do that well.
Okay, Dr. Ayman, if you have any.
In fact, yeah. Thank you, Carlos, for these very nice videos, elegant surgery. What I do, in fact, I started doing vitrectomy and injecting TPA But what I do now, I inject in more than one site. If the hemorrhage is massive, I inject in 2 or 3 sites rather than giving an air with my TBA because of the fear of the foveal rupture and creating a macular hole. I don't do RP transplant, but one thing that I want to add, in one of my cases, I did one case with vitrectomy, injection of TPA. The patient improved from hand movement to 0.2 vision, but 2 months later she had a recurrence. I discovered that she get back to her anticoagulant. She had a heart problem and she was on Plavix, and I think this is an important cofactor in creating bleeding in cases of AMD. So just to be sure that patients are not taking, if it's not that necessary, the anticoagulant. But definitely it's elegant surgery. Regarding the retinal pigment epithelial transplant, I know it's a big surgery. The results are not always good, but in some cases, yes. If the patient is one-eye patient, he has very poor vision, I think it's worth trying.
Thank you, Dr. Ayman, for your comment, Dr. Pramod, for your comments. There is only one question from my side, Dr. Carlos. How do you fix the this one retina you cut and you put it on the, how you fix it?
How you fix the RP transplant, is it correct? No,
Yeah.
you put it over, you are under perforocarbon liquid, you have the retina flip over, and then you have perforocarbon liquid there, and then you begin to inject under the retina and in the previous cavity, and then you are removing the perforocarbon liquid and injecting in the other side, and then you flip the retina over its place, and it stays there. The problem is that you never know where exactly the fovea is, because you don't see the the yellow pigment. You see the RPE atrophy, but not the yellow pigment. I absolutely agree, but again, there's a clear difference, as both of you mentioned. There's a clear difference between subretinal hemorrhage, that the prognosis may be good, as I show you one case, and sub-RPE. Sub-RPE, the prognosis is very poor. Even if you inject RTPA, you inject whatever under the retina, at the end, you have a scar, terrible scar in the center. It is my experience.
There is one from dear friend, Dr. Mandeep Lamba. He's a veterinary surgeon in Dubai Hospital. His comment: many times these large subretinal hemorrhage break through into a vitreal cavity. Would you like to wait and see if that happens rather than rushing to the subretinal surgery?
No, I don't wait, because this blood goes to the vitreous cavity, but the scarring process, is there. And then you wait, and then you have a big scar. Then, I don't wait. If the patient has very poor vision, vitreous hemorrhage, I go there and I try to do my best. I understand that this is under, you can argue hours and discuss hours if this is convenient or not. Because of this, I brought this case for you to discuss this. But in only one eye, not if the other eye is fine, of course. But in only one eye with very poor vision in the other eye, I would try it.
So I think maybe if we have to conclude from your cases in subretinal hemorrhage, the prognosis is very less. But if there is a patient is having a very poor vision, I mean light perception in both eye, and you can improve the vision in other eye, only a hand movement or counting finger, it changed his life. I think, yeah. I think this is, we can stop by this one. We already. Okay, how about injecting tab vitreous cavity? There is one question. How about injecting tab in vitreous cavity?
In RTPA?
Yeah.
Yeah, but RTPA is fine, but there is a doubt that if RTPA enters in the subretinal space, there's a lot of papers saying that that it doesn't go through the retina. Sub-RPE, nothing. This is nothing.
Okay, there is the last question before, because already we are on the time. How to be sure that FBO is not subretinal pigment epithelium choroidal transplant while transferring it from the host area to the macular area?
How to what? Excuse me? Repeat again.
How to be sure that BFO is not subretinal pigment epithelium choroidal transplant will transferring it from the host area to the macular area.
Yeah, with the perforocarbon liquid, you have a big problem because, you know, it's very easy to have bubbles. But, you know, if you don't elevate the tissue, you won't have RP, you know, perforocarbon liquid under the graft, but you can have some, you know, bubbles of perforocarbon liquid. I had in the last case, you know, some bubbles in the subretinal space. You have to, at the end of the surgery, you have to be sure you don't leave any bubble under the retinal. Yeah.
Thank you very much, Dr. Carlos. Very interesting. If we continue with you, we will not finish the webinar. We will continue only on this topic. So I would like now to...
One thing, Muhammad.
Yes.
I tried both. I tried injecting the subretinal TBA using the 41 gauge needle, and I tried injecting the vitreous, doubling the dose and injecting inside the vitreous. Definitely injecting in the subretinal space is definitely much better. This is one. And I have an experience with two cases with a little bit of subretinal pigment epithelial hemorrhage. The prognosis was not bad. If the hemorrhage in the subretinal pigment epithelium space is not that huge, it usually subsides with very, very minimal scarring.
Thank you very much. 1 minute from your side. I will take it, Dr. Ayman, for the last comment. It's okay.
Okay, it's all right. No problem.
It's now my pleasure to introduce Dr. Ayman Midanat. Dr. Ayman Midanat is an MD, Bachelor, FRCO Ophthalmic, FRCS Ophthalmologist, RCOBS, Senior Consultant Ophthalmologist and Retinal Specialist. He's an ex-head of Ophthalmological Department at Royal Medical Service. He's an ex-president of Jordan Ophthalmological Society, ex-head of the Scientific Committee of Ophthalmology at Jordan Medical Council. He is the general manager of Amoon Eye Center in Jordan. Dr. Ayman, it's our pleasure, please.
Thank you, Dr. Muhammad. Thank you again for this invitation. And I want also to thank John for his cooperation. Good evening, everybody. My talk today will be about endophthalmitis post intravitreal injection. We all inject anti-VEGF every day. And the endophthalmitis, in fact, although rare, it has a devastating effect when it occurs on vision. So prophylaxis is very important. I'll tell you what I do. I check every eye for any sign of infection or inflammation before the procedure. We use to book patients for injections. I don't send any patient to the theater before examining him in the clinic to see if he has any problem, uveitis or infection or STI or anything. We follow a written protocol to prepare the patients. We put one drop of anesthesia, and after 1 minute, we put another drop. Then after 2 minutes, we put 5% betadine solution into the conjunctival sac. And after 5 minutes, we take the patient, after we put another topical anesthesia, to the theater. In the theater, we do the painting with betadine, the draping in a sterile theater, or some of my colleagues, they do it in a sterile minor procedure room, no problem. Sterile speculum, and I sometimes do the 2 eyes. If I'm doing the 2 eyes, I do 2 sets of instruments and drapes. And another betadine drop, I put it before injecting immediately, and I don't wash it. Personally, I prefer to use sterile gloves and masks. I don't use any antibiotic drops, but sometimes I give artificial eye drops to help patients to wash the rest of the betadine from the eye. I found it helpful, in fact. This slide is showing, in fact, the causative organisms in cases of endophthalmitis post-phaco and post-intravitreal injection. We noticed that the coagulase negative staph is the most common cause in post-injections, comparing with the phaco cases. And we can notice that the strep bacteria is the second most common cause. Well, management. In endophthalmitis, there is 3 stages. The incubation period stage, and the acceleration, or what I call it, the fulminating period or stage, and the destructive period or the destructive stage. It's very important to start treating during the accelerating or fulminating period. We don't wait for the destructive stage to happen. Definitely vitreous biopsy and intravitreal antibiotics within 1 hour of diagnosis. I don't use, I found using needles is not helpful at all. 23, 27, it's not helpful, you know. In most of the cases, I use a small gauge vitreous cutter to take a vitreous biopsy, and we inject vancomycin 1 milligram, 0.1 mil, and ceftazidime 2 milligram, or cefotoxime. Recently, I'm using the cefotoxime. It gives a very good results. The endophthalmitis vitrectomy study guidelines does not apply properly for the post-injection endophthalmitis because of different incidence of gaugative organisms and clinical course. So the guidelines for vitrectomy and the endophthalmitis vitrectomy study does not apply correctly to our cases. But what I do, in cases I do vitrectomy, in fact, in severe cases, when the case is severe at presentation, like when we have less visual acuity, less than counting 1 meter, we have a significant anterior chamber fibrinous reaction, severe vitritis as shown by the ultrasound, severe lid edema, etc. Or if the patient or the eye is not responding or is worsening after giving intravitreal antibiotics, or if there is a persistent vitritis. This is where I do my vitrectomy. In fact, nowadays, you know, the techniques, everything is much more advanced than 1995 when the vitrectomy study appeared. I'll show you this case. This case is my case, in fact. This is a 75-year-old diabetic patient with bilateral diabetic macular edema. She had 3 Avastin injections 1 month apart in both eyes. She presented 5 days after the 3rd injection with pain and loss of vision in her right eye. This is her right eye. You can see the cornea is a bit cloudy, fibrinous reaction, hypopion, and the vision was counting fingers. I decided to go ahead and do vitrectomy for this lady. What I do, I insert first the stroker to try and take biopsy. I use, in fact, the cutter and without putting any irrigation. Then I aspirate what's present in the tube and I send it for culture and sensitivity. I take also from the fluid. It's not from the fibrin, the anterior chamber. I take from the fluid also a sample and I send it for culture and sensitivity. You can see when we went back to the vitreous cavity, there was a lot of vitreous haze and pus in the vitreous. I couldn't see the retina at all, and you can see it now. The patient was pseudophakic, so that made life easier for me. So I did proper vitrectomy. If you can remove as much as vitreous and pus from the eye as you can without jeopardizing the retina. It's very important not to create any retinal tears or holes during your vitrectomy, or the case the end result will not be good. But try to remove as much as you can of the vitreous. Don't attempt to do vitreous phase separation, because if it's easy, yes, you do it, but if it's difficult, leave it. You don't want to create any tears in the retina. I used to indent and remove the vitreous and the pus from the retinal periphery if I can, under vision. It's very important, as I said, not to try and injure your retina. At the end, I inject my antibiotic and I inject 0.4 milligram of dexamethasone. This was the result. The patient went back to 0.5 vision. This was her baseline vision before infection. Case number 2 is not my case. In fact, it was referred to me. He was a 48-year-old male patient. He's diabetic for 16 years, type 2. He presented to our center with history of loss of vision in his right eye for the last 2 weeks following intravitreal injection of Avastin elsewhere. The patient reported loss of vision 3 days after receiving Avastin. His physician gave him intravitreal antibiotic, and he was followed up. His vision did not improve. In fact, he worsened, and he came to me 2 weeks later with this picture. His vision was perception of light, was his only eye, he was blind, so we went to vitrectomy. The problem with this patient, he has cataract. The lens was cataractus, and we have to remove the cataract. There was no view at all. So I went in, we removed the pus, the fibrin, of course, after taking the samples from the vitreous and from the anterior chamber for culture and sensitivity. The lens was a little bit hard, and in fact, it was totally opaque, and it was not an easy surgery, especially when you are lacking the red reflex, but we managed to remove the lens completely, and we cleaned the lens cortex. You cannot see the cortex at all, but we managed to remove it. Going back to the vitreous, it was a hell. You cannot see anything. It's really all of it. It was totally opaque. The posterior part of the eye was full of pus, only pus. You cannot recognize where is the retina, nothing. So you have in these cases to be patient, to stay, try to stay in the middle, try not to injure the retina, because if you injure retina, if you create breaks, this is the end of the case. The patient will not improve that much. So in these cases, you have to be patient. Just be patient, remove the vitreous bit by bit until you see the retina, or if you can see the blood vessels, or if you can see any landmark of the retina. This would be your reference, and from here things might become a little bit easier for you. In this case, you can see the hemorrhages. Now, I realize that I am over probably the retina because I can see the hemorrhages. The patient is diabetic. And if you can notice, the disc is over here. You can see it now. After removing all this fibrinous material and removing all this pus from the back of the eye, now you can notice that the disc is over here. So I know that my macula is here, and I started to orient myself, and the surgery becomes a little bit more easy. You can see the disc here. In this case, I indented also, and I tried to remove the vitreous and the pus and the fibrin from the retinal periphery as much as I can. And I inject vancomycin and cefotaxime and dexamethasone. This was, the culture was, in this case, Streptococcus viridans. I was astonished because this patient has had intravitreal antibiotics 2 weeks earlier, and still we could culture Streptococcus viridans. In the first case, the culture was negative. We could not culture any bacteria, but in this case, 2 weeks later, we could culture Streptococcus viridans. This was the 1 week after surgery. This was 2 weeks, 3 weeks, and 4 weeks after surgery, this patient was corrected to 0.1 vision, and he's back to and hopefully to a navigating vision. So my take-home message is that post-intravitreal injection endophthalmitis is a potentially devastating situation that need to be dealt with promptly. Intravitreal antibiotics should be started within 1 hour of presentation. The second case showed growth of streptococcal bacteria after intravitreal antibiotic injection, necessitating the need of repeated injections. Some patients, they need repeated injection. You just don't give one intravitreal antibiotic injection and say that's it. Some patients, they need more. And when PPV is indicated, should be done early and without delay to avoid destruction and subsequent loss of vision of for the patient. Thank you very much.
Thank you very much, Dr. Ayman. Very interesting cases. We will have now refer to Dr. Carlos, Dr. Pramod, and other panelists. If there is any question to Dr. Or comments about.
I have one question. In the first case was a mild endophthalmitis, simple case. But in the second case, there is a wide, areas in the retina, hemorrhages, and all this stuff. In the first case, you mentioned do not remove the posterior highlight or don't try to promote traction. But if you leave silicone oil as the second case, do you think that this is important to remove the posterior highlight? I know the risk because it's very atrophic and very ischemic, the retina, but if you don't remove the posterior highlight in these cases where you are going to leave silicone oil, then you have a contraction of the posterior.
Yes, yeah. I got your point, Carlos. Yes, you're absolutely right. If you want to put silicone oil in an eye, it's definitely you need to remove the posterior vitreous phase. In the second case, I don't think there was any posterior vitreous phase with all this fibrin attached to the retina. So all the vitreous has been converted into pus and fibrin. And as you noticed, I tried to remove every fibrinous material from the surface of the retina, so because I was intending to put silicone in that eye. In the first case, it was not that difficult case, although the vision at presentation was counting finger close, but the retina looked fine. There was nothing. There was no pus under the retina. But the vessels, the disc was fine. In these cases, if you want to do posterior vitreous detachment, you can do. But I didn't find any reason to do that in the first case. And as I said, in the second case, I tried to remove as much of the remnant of the fibrinous vitreous from the surface of the retina as much as I could. Although you cannot definitely prevent scars and fibrosis post-op. So what I did is that I removed the silicone oil 6 weeks after this surgery. I showed you the photograph of the patient 4 weeks after surgery. He was recovering very well. So 6 weeks after surgery, I went in, I removed the silicone oil, and I put an IOL because I left the posterior capsule intact, and I put an IOL. And when I put an IOL also, I did a posterior capsulotomy, and I re-inject antibiotic again. The patient is well, and his vision is 0.2, and he's happy, and I'm happy. Thanks God. We were lucky.
Thank you, Dr. Ayman. Thank you, Dr. Okay, any question? Yeah, Dr. Patricio.
Dr. Ayman, nice talk. Thank you for your presentation. How long you wait before deciding on going ahead for a second or a third injection? And then when you go for them, do you take samples from the vitreous for culture? And if you do they come positive?
This is the first time I had a positive culture after intravitreal antibiotic injection. I was astonished, in fact, to get when the report came back to me that the patient have Streptococcus viridis. I want just to, before answering, want to raise one important thing, that Streptococcus viridis is present in the oral cavity and upper respiratory tract. So I think that it's mandatory. It's very important to try and put mask when you are doing injection, or as some of my colleagues say, we don't talk, we don't speak. And I find it difficult sometimes not to speak to the patient when I'm doing the injection. Regarding the repeated injection, when I repeat my injection, if I have a case of endophthalmitis, I treat it medically, and I see that the patient is improving, the hypopyon is gone, but there is a little bit of vitritis still and some reaction. I would repeat the injection after 1 week, because the half-life of the antibiotic inside the eye is around 3, 4, 5 days maximum. So after 1 week, I repeat my injection if I see that the patient is responding well. But I don't take another cultures. No, if I have a positive culture from the beginning, I don't. And even if I don't have a positive culture from the beginning, it's very difficult to have any positive cultures later on after injecting of the antibiotics.
Thank you.
Thank you. Any other question from the panelists? Dr. Pramod, if you have any comment, Dr. Karina?
Basically, I think everything we have discussed, but using silicone oil is a little bit debatable issue, because if we do not have any break created, and which intend to I would prefer to have as much debulking as possible without creating the retinal break. Unfortunately, if it happens, then obviously I'll go outright, clean all the vitreous, induce PVD, base excision, and then laser and oil. But as far as possible, I would stop most of the time. Once I start seeing retina, reasonable debulking, I stop there. There are few published reports that intentionally doing base excision and filling silicone oil and 360 laser, and they have quoted few good results. But personally, I still prefer to be conservative when dealing with these eyes, because the retina is inflamed. If necessary, yes, second setting, I will go inside to remove the remaining debris. But as a primary setting, I would prefer to have as conservative as possible.
Thank you, Dr.
I agree totally. I said it's you should be cautious in your surgery. You should try not to jeopardize your retina. Whenever you're doing these are difficult cases. It's not easy cases. You have to be patient. You have to try and remove as much of the vitreous and inflamed and infected vitreous as much you can, but don't jeopardize your retina. I don't use the silicone that much, but this patient was a one-eye patient. I had to use silicone in this case.
Absolutely.
We have a question about silicone, but you already answered. We have two raised hands. If we can get Dr. Muhammad first and then Dr. Mandip. And please, from dear panelists, if you can give a short answer, it will be more for the sake of the time. Dr. Muhammad, if he is there, open the mic for Dr. Muhammad and Dr. Mandip. Dr. Ahmed Al-Barqi also is there. We need also to ask dear friends to be ready to open for them the mic so we can save the time, and to have a very short question, and then we need only a very short answer, dear colleagues. Meanwhile, to open, if they are not yet there, we are having one question. Dr. Ayman, do you check a blood glucose level pre-op? If yes, at which reading you cancel the injection procedure? Very...
It's very important. If the patient is having hemoglobin A1C 10 or 12, I still give my injections, but I tell them to control their diabetes, because I cannot wait. Sometimes it takes weeks, takes months for hemoglobin A1C to go below 7. So you don't delay treatment. You give the treatment and you instruct the patient to control his blood sugar.
Okay, Ahmed Al-Barqi is there on live.
Hello.
Ahmed, مساء الخير. تفضل حبيبي.
السلام عليكم. Hello, السلام عليكم. Thank you so much, Dr. Muhammad. Habibi, Dr. Ayman. Thank you so much, and thank you for Carlos. Very interesting cases. I just have a very, as Dr. Muhammad said, very short question, quick questions regarding the second case, Dr. Ayman. Yes. Doing phaco in endophthalmitis case, it's very challenging, and especially in those cases that you have endophthalmitis post-injection. So it means that this patient was doing OCT regularly. So the density of cataract does not that much to get OCT picture. So do you think that doing phaco in endophthalmitis with everything is inflamed, corneal endothelium is not healthy, iris, do you think it could be this postponed or trying to do it, avoiding this, or what do you think?
Excellent question, Ahmed. In fact, if the cornea is clear, if the lens is clear, I don't attempt to remove it. Even if there is a little bit of lens opacity, I would leave it. But in this case, there was a significant cataract. I couldn't leave the lens because if I left it, I would not have done a vitrectomy at all. So I had to. You've seen it. It's a hard, completely opaque lens. I had to remove it.
Okay, thank you.
Okay, just when we're taking QV, Dr. Ahmad, what he has a doubt he now said, and you said lens was wobbly. Do you think probably like previously if OCT could be done, considering lens was reasonably bigger, and now on table you have a dense cataract, is probably secondary to inflammation, or probably previous injection led to lens touch as well, and then this cataract is related to that?
In fact, anything could happen, and I think this patient had some cataract before. He's diabetic, and I think the inflammation has aggravated his lens opacity.
Can you open for Dr. Muhammad or Dr. Mandi, please? Please, Dr. Mandib, if you are there, just unmute yourself, please. Dr. Mandib or Dr. Muhammad.
Good afternoon, Dr. Amri.
Yeah,
good evening, gentlemen.
Yeah,
my question was regarding silicone oil. So that was already discussed with Dr. Pramod Bhinde. So I think that's done. You can go ahead. Thank you.
Okay. Did you second the case had? Okay, this is the one. Right. Thank you, Dr. Mandib. Can we have Dr. Muhammad if he is there? Meanwhile, we are having whether IOL could have been implanted in a second case or not.
Not at the first sitting. I did not. In fact, I don't advise implanting a lens in such cases and very, very severe endophthalmitis. An IOL was implanted at the time of silicone oil removal. It was a secondary implantation. Yes.
Okay. We have another question. Why silicone oil was used as a tamponade in a second case?
Because the patient is a one-eye patient. He's a one-eye patient. I need him to see. I could not use gas. It would be difficult. And the silicone oil itself is antibacterial. When you are, it acts against bacteria whenever you put silicone oil. So it helps.
Okay. Also, I need a very short answer, Dr. Ayman. How many times we can give IV antibiotic? What are the parameters that determine number of injections? I know you answer part of it, but how many times do you think we can go before you decide?
In fact, yes, this is an excellent question. In fact, you can go up to 2-3 times if you find that your vitritis is decreasing and patient is improving. But if after the first or second intravitreal antibiotic injection, you find that the response is not that much, you go ahead and do vitrectomy. But you can go up to 1, 2, 3 times. You can, no problem. Because as I said, the half-life of antibiotic inside the eye is not more than 5 days.
That question he was asked by Dr. Qasim Al-Hamouri, so he is sending a regard to you, Dr. Ayman.
Dr. Qasim is a dear colleague, and we work together. Tahiyyati ilo.
Okay. If a patient was not one eye, in which patient silicone oil is used?
Again, sorry, I didn't follow.
If a patient was not one-eyed,
yes.
In which patients silicone oil is used?
In cases as the first case, and in fact, I showed the 2 cases to show that early vitrectomy is really, the results are much better. If vitrectomy is indicated, you have to do it very early because you don't want to reach the destructive stage as in the second case. Any severe endophthalmitis as the second case, I prefer to use silicone oil.
Okay. We need the last question because we are having many questions and we are already exceeding the time. Dr. Ayman, you are presenting all the time a very interesting case. So we are taking time more than what is supposed, but it's our pleasure. What is the debate in using antibiotic drops pre-op? My recommendation he is saying, my recommendation is to use bisfloxacin suspension drop, which can penetrate between lashes and give you a guaranteed pre-op sterile sac. What is your opinion? Want your opinion, okay?
I'll tell you. There was a study comparing the ofloxacin to ciprofloxacin. They found that ofloxacin is better used as a prophylactic, although there is no definite study to show that it's working as a prophylaxis. But some of our colleagues is using it 24 to 48 hours before surgery as 4 drops, and they are using it half an hour before surgery. They are using ofloxacin. Now, the levofloxacin has more ability to penetrate the cornea. So they're using also levofloxacin 1 day and half an hour before the start of surgery. How much this will prevent endophthalmitis, it's not clear.
Okay, thank you, Dr. Ayman. Also, that question also from my dear friend Qasim Al-Hamouri. Anyway, thank you. Now I would like to introduce my dear friends. If you can start sharing your Dr. Pramod. Dr. Pramod is a consultant ophthalmologist, director of vitreoretinal service. He is Sankara, Netherlai, Chennai, India. I hope that I mentioned it, I read it correctly, Dr. Pramod. And appreciate you are accepting our invitations. The mic.
Thank you very much. Am I audible? Shall I start?
Yeah, please. Yeah.
Yes, yeah, it's a short presentation. Now we have a 60-year-old male, had a right eye, had a squint surgery 35 years back, had a cataract surgery with IOL implantation 7 years back, and he had a radial segmental buccal for superior temporal retinal detachment in 2011. Subsequently, he had exposure of the buccal along with rigor and detachment, so he underwent buccal removal for exposed buccal, followed by vitrectomy and rebuckling along with silicone oil injection. Now, day 1 post-surgery, intraocular pressure was normal, retina was attached, but he had a 360-degree choroidal detachment, probably secondary to inflammation previously and added on vitreous surgery. So he was treated with topical steroids and cycloplegics and also put on systemic steroid and tapering doses. Over 1 week or 2 weeks, with this management, choroidal detachment reduced, especially nasal part and inferior quadrant. So subsequent follow-up at 1 and 2 months, vision improved to 612 and 6 in the right eye. Anterior segment was quiet, pressure was normal. Fundus examination revealed clear vitreous cavity, attached retina, but he still had a persistent choroidal detachment in temporal part and superior quadrant. And the condition was status quo at 3 months, 4 months, and 6 month follow-up. And so that was a stage. 8-month follow-up, when conditions remained like that, he was referred to us for further management. And when we examined him, he was asymptomatic. Vision was 624 N6. Intraocular pressure was normal. As you see here, anterior chamber, it's a pseudophakic eye, absolutely quiet eye here. Fundus examination, what you see here is choroidal detachment on a temporal side and superiorly. Inferior retina is attached. And if you see, this is a meniscus, incomplete field of the silicone oil. So that is what a picture here. Ultrasonography we did to check why the choroidals are. So as you see, elevated choroid here, and equilucent suprachoroidal space, and rest of inferior retina was attached. And now we have a question: what could have caused this persistent, apparently serous choroidal detachment, and how to manage? Probably, I think I stop here. We can have some discussion, and then we go ahead further. I update my case later on.
Okay.
I stop sharing for a while, so maybe we'll take few. Debate, and then we'll proceed further.
Dr. Ayman, if there is any comments or what you will do. Carlos, if this is the case and came to you, what are you going to do? This is, I think, the question of Dr. Pramod. Am I right?
Isn't there Dialogues drugs or something, some drugs in the for the controlling the pressure or something?
Well, he is a no systemic disorders. And he was not on medication when he reported to us. No medication for the eye at all. Mm-hmm. And because, to remind you, it's an 8-month post-surgery follow-up, and eye is absolutely quiet except choroidals.
Well, I never saw a case like this. If there is no silicone oil under the choroid. I don't understand. So I saw some cases with silicone oil under the choroid. Then, you know, they stay forever.
Let me ask you, Pramod, about the intraocular pressure after removal of the buccal the first time. Did you have any hypothesis?
When a first time patient was up, because he was operated outside, so I do not have that information. But immediate post-operative patient pressure was always normal, never hypotony or not even high pressure. Somewhere between recorded pressure is 12, 14, 16, so not really high pressure.
My second question, how is the general condition of the patient? Is he hypertensive?
Patient is absolutely healthy, no systemic disorder at all.
Nothing.
Yeah.
And this subchoroidal hemorrhage happened just suddenly?
Well, no. From the first day of surgery, whatever notes we could go through, he had 360-degree choroidal detachment with a steroid, systemic and topical, inferior and nasal choroidal detachment subsided, but superior and temporal choroidal detachment persisted. And that persisted till almost 8 months, till he reported us.
I think this is maybe a very difficult case. Okay, let us see what you have done and what you found.
Yeah, sure.
There is a question, could it be buccal related?
Well, he had a buccal, obviously, revision buccal, and but buccal, there's no reason. It should be a localized area where you have a buccal. So you have a buccal indentation, but ultrasonography obviously clearly mentioned that there is suprachoroidal space. Echolucency is there. Okay. Of course, it's an echolucency place, so there is no hemorrhagic choroidals. They either apparently probably serous choroidal detachment.
Some suggestion is due to presence of silicone oil.
Yes, so probably will come. So what happened? Let me hold on this video. So we gave a patient the option whether we should go ahead, because anyway 8 months, we do not know why choroidals are there. So ask patient whether shall we go ahead with oil removal and choroidal drainage. The other option was just wait and watch because he is asymptomatic. So patient agreed to go ahead with surgery. He said, okay, anyway, it's time for oil removal. Pressure is normal, eye is quiet. Let us go ahead with the suprachoroidal drainage. And what we realized when you did choroidal drainage and what is happening, you see here, when you cut the sclera, what is coming out of the suprachoroidal space is, this is what?
An oil.
It was a suprachoroidal silicone oil. And the choroidal detachment basically is a choroidal elevation due to suprachoroidal silicone oil. That is what Dr. Carlos has a question. It looks like oil. So we reformed to build up the intraocular pressure. We injected saline in a vitreous cavity, BSS, to build up pressure again. Some more oil we drain out. We could flatten the choroidal detachment by draining this, and then we proceeded with oil removal. So that's the end of the case here. We suture it back. So the question again now come back, how would you suspect suprachoroidal silicone oil? Now the same, what I already said, would you observe or plan silicone oil removal in this asymptomatic patient with attached retina, normal IOP? And what would be the consequences if oil were left behind in this eye?
Let me tell you, Pramod, I saw an image like this. I had a case of this.
Yeah, sure.
Where you inject silicone oil, if the cannula goes out a little bit, you can inject and you don't notice. And you can inject silicone oil under the choroid and into the choroid. And then I had one case of this. Because of this, I thought about it. Yeah. But I
agree.
After.
Totally agree with you, and that exactly my hypothesis was. And particularly when we are using this angle, we are having a trocar cannula system, and where we are not suturing. And when you want a self-sealing sclerotomy is you have a tendency to go more oblique. And if you are partly in a suprachoroidal space and partly in a vitreous cavity, you think fluid is flowing inside the eye. So, but when you inject, probably you are partly injecting silicone oil in a suprachoroidal space also. That is one part of it. Or just before injection, inadvertently, partly a cannula get pulled out to some extent. Initial surgery went off well, but while inadvertently some tug somewhere. So, but it's still oil is going in a vitreous cavity. So you are happy, but you don't realize part of it because of oblique entry. You are still injecting a suprachoroidal space. So that is what is hypothesis I also had. We have 3 cases like this. So now in this, that's a part of hypothesis or theory of what we have, how oil can go in a suprachoroidal space. We have one case where we remove the oil intraoperatively. We realize that oil is going in a suprachoroidal space. So we really cut internally itself, made a choroidotomy from inside, put perfluorocarbon and brought back that silicone oil in a vitreous cavity itself and drain. That's another way we did, but this was a totally different case. This was subsequently came to know that oil is there. So also clue here was there was an underfill of silicone oil. On that even on table, when a note says there was no choroidal detachment, I was properly filled with the silicone oil. Why we should have underfill in a post-operative period? Probably that could have given a clue that most likely part of oil could have gone in a suprachoroidal space. So,
Dr. Pramod, can I ask, how the choroidal, it was in all 360 degree, and some area they are responding to, if we say it respond to steroid.
agree.
That one, it may give also, this one, it's also is a something is to make you not thinking about the silicone oil or not.
Exactly. So that was a misleading thing because initial response was there with the steroids. So we thought it's an inflammatory response and they may settle down. There is a possibility, yes, it's partly inflammatory, partly serous component as well, not totally only silicone oil, and which serous component has settled down with our steroid treatment, anti-inflammatory treatment protocol, and that actually must have misled this operating surgeon that he was dealing with a serous choroidal and not having a suprachoroidal silicone oil.
Okay, thank you very much. Very interesting case. If we can go to
so just to complete, this is a follow-up. Unfortunately, as I said, we removed the silicone oil and this was 612I, and after 3 weeks, he came back with a recurrent detachment with the PVR. We have to take him for another surgery, unfortunately. So then forced me to think about whether I should have left it.
I have a question for you. You mentioned
Yes, sir.
Drain through the inner part of the retina, through the inner from the vitreous cavity. You mentioned this.
That's right.
Correct?
Yes.
I'm very afraid of this because I did, for other reasons, I did once or twice, and then the choroid remains detached forever. Then the choroid tends not, and there is no force to maintain the choroid there. Then it remains detached. And for me to try to drain inside the eye, it's a big problem. I prefer outside the eye, through the sclera.
Yeah, I agree. Totally agree with you. But this is one isolated case where we realize oil is going inside, suprachoroidal space is bulging. So there was an opening there where infusion cannula was poking through. So we just enlarge that opening bit, fill the eye with the perfluorocarbon, and when it's filling up, it squeeze that oil sort of squeeze out through the same opening, not making the large opening. Yes, what you rightly mentioned, it can happen particularly you are dealing with the trauma cases where you have a large choroidal detachment. There is a gap, oil going into that gap, and then it's already sort of epithelialized and scar. That choroid will never go back.
Okay, it's a very interesting case, Dr. Pramod. We can go to the second one. We have 2 questions. We will keep it till the end of the session.
Yeah, so we'll go with the second case.
Yeah. We will try to be fast in the second case.
Yeah, very quick case. Okay, so now this is a 53-year-old female, uncomplicated cataract surgery 7 months back. She developed noticed redness pain, and loss of vision 20 days following surgery. She was diagnosed as a post-operative endophthalmitis and underwent vitrectomy elsewhere 1 month after surgery. Eye was quiet. She underwent capsulotomy 2 months after that, but there was not much visual improvement. Left eye was normal. Now, when she reported, her vision was counting finger in the eye, operated eye. She has a scleral nodule and pus pointing at the inferior temporal quadrant. We thought probably we are dealing with infective scleritis, and that was the sclerotomy site location, inferior temporal sclerotomy. She had a mild corneal haze, deep anterior chamber, minimal hypopyon, fibrin over eye well. Fundus, we could see, though view was hazy, but it was normal, vitreous cavity was clear. And when we did anterior chamber tap, we got many pus cells, but there were no bacteria, no fungus, no growth on the culture. PCR was negative for eubacterial non-fungal genome, no P. acne, no MTB. But the scleral scraping, when we send for a culture, it shows all here is a acid-fast rods. Okay, there are plenty of acid-fast bacilli, but did not show any growth of Mycobacterial tuberculosis on a backpack. Well, so we started her on topical steroids, cycloplegic, ciprofloxacin, cefazolin, systemic steroid, antibiotic, trying to treat as endophthalmitis. But now the scleral nodule, which we scrapped, now came back. Initially there was no growth. Now it turned out to be growth shows Mycobacterium abscessus. This is something different we never saw. And we have a sensitive pattern of all these drugs you see here. So we change our treatment plan to amikacin and moxifloxacin because what we've gone through literature, we realized Mycobacterium abscessus is sensitive to amikacin. Patient went back to his local ophthalmologist following him and then come back after 5 weeks, and as you see is a devastating picture. Though light perception drop risk, no fundus view, you see neovascularization over the iris, you have corneal edema, you have deep anterior chamber, exudates filling the pupillary area, you have granuloma, which is vascularized, and again enlarged scleral nodule. They are much bigger than what it was before. However, ultrasonography still reveals clear vitreous cavity attached retina. Now, when we see all these things, we wanted to revise our diagnosis. We thought maybe we are wrong. It's not a Mycobacterium abscessus because as per sensitivity pattern we are treating. So we want to revise probably whether we are dealing with fungus, whether we are dealing with another tubercular galloma, we did not know. So we decided to go ahead again scrapping. We did revitrectomy. This time we removed intraocular lens also, and whatever pupillary membrane, wanted to do clean job. So again, IOL and vitreous aspirate, no growth. PCR of vitreous aspirate, negative for any organism. So we decided because there is no fungus, let us continue with amikacin and moxifloxacin. But sprayed acetate we cut down because we're still not sure whether what we are dealing with. So we just nominal dose twice a day. Patient goes back, but again, what you see here, scleral packing persistently showing acid-fast bacilli. So we did DNA sequences this time, all this confirmation, something like take a hits, shock protein 65 and restriction fragment length polymerization, which is targeting HSP65 gene, which is very specific of Mycobacterium species. This is non-tubercular Mycobacterium species. They are very specific. I can't go in detail because I'm not a microbiologist, but this is what our microbiologists conveyed, that you are dealing with non-mycobacteria, non-tubercular Mycobacterium, and they put it as a Mycobacterium abscessus. Patient goes back and come back after 1 month, and a look at this picture is again disturbing, very devastating. Now you see dilated tortuous vessel. This is now abscess or nodule, scleral abscess here, corneal section, limbal section, cataract section has given up. You thick pupillary abscess and membrane, and no fundus view, but still ultrasound shows attached retina, clear vitreous, hardly any vitreous echo. We did not have any choice, but this is not a salvageable eye, so we decided to go with enucleation. And what we got an enucleation where this is a gross specimen, vitreous cavity full of caseating material, as you see here, and giant cells, typically of, again, Mycobacterial endophthalmitis. So basically, this is the case, something like a Mycobacterium abscessus. Just let me quickly go through what it is. It is a rapid growing gram-positive, non-motile acid-fast bacilli, commonly seen in a soil, water, and dust. Incubation period is somewhere 2 weeks to more than 1 year, as you mind here. mean interval generally between somewhere 13 to 24 weeks. And generally seen in keratitis, particularly crystalline keratopathy is following LASIK is a known, and it can cause scleral buckling infection and orbital infection. And it can be viable for as long as 6 months to 12 months following keratitis. So extremely difficult to culture and treat. Amikacin is supposed to be very susceptible, almost 81%, followed by clarithromycin. But very typical here and interesting, something called that inducible resistance over time. There are a couple of reports showing that initially organism is sensitive to clarithromycin, but after a couple of weeks or same culture, after 2 weeks or 3 weeks, you see then organism is resistant to clarithromycin, something they use the word inducible resistance over time. So there are a lot of penetration. So generally have a delayed onset endophthalmitis. Generally again entry during your cataract surgery when you open the section, your patient can present with perivasculitis, little bit vitritis, vitreous cells over the disc, chorioretinal infiltration, and choice of drug is obviously topical amikacin and systemic also moxifloxacin and amikacin if necessary. And typically with vitrectomy and antibiotic, intravitreal antibiotic, systemic antibiotic, there are quiescence, it get quiescent, but they have a stages of quiescence and you have recurrences, waxing, waning course, and eventually almost all the report I could look through, these eyes eventually over a period of maybe 1 month, 2 months, sometime up to even 6 months, eventually go through evisceration and enucleation. Who generally over our poor prognosis because higher incidence of misdiagnosis, delayed diagnosis, and in spite of having a sensitivity pattern with you, somehow these organisms do not respond that well to those sensitive organisms, to the antibiotics. And also cluster or colonies are seen behind the iris, they remain dormant. And as you stop the medication or organism develop resistance to the drug, again, they flare up and come back with recurrent inflammation. So that is what one case I wanted to discuss, something different than what routinely we see.
Thank you, Pramod, for this interesting cases. And lastly, if there is any comment, this one, I think Dr. Karina and Dr. Batisho, they will have an input if they want to ask Dr. It's a very difficult case, actually. So you present a most difficult cases, Dr. Pramod. Any comment, Dr. Batisho or Dr. Karina, or any question, Dr. Carlos, Dr. Ayman?
Dr. Pramod, this is very, very nice presentation. I want just to say one thing. This is a very uncommon bacteria causing endophthalmitis. And usually in these cases, the end result and the visual prognosis is really bad. This bacteria grows in water and dust, and most of the time, the contamination probably is due to the surgical instrument itself. The patient, everything has been done, but the patient is unlucky to have this type of infection. Usually in this type of unusual bacteria, the prognosis is really bad. Very interesting.
Yeah, and that's exactly consistently what you rightly mentioned, entry of the contaminated instrument. That's why you have the scleral nodule where inferior temporal sclerotomy site probably consistent. That is the area we could get consistent positive culture.
I agree, absolutely. Thank you.
I wonder if we are dealing with a granulomatous disease, and I'm sure Dr. Karina will have something to say, covering this resistant germ with several different antibiotics and maybe systemic steroids, if they can have any role in a granulomatous disease?
Yes, probably. Yes, probably. When you look back, I agree. Yes, because when I was going through literature, but all these things happen, we discuss once we experience this and time has lost. And when you look at it, I was looking through literature. So particularly when this mycobacteria we are dealing with, they have suggested now will be try and not to treat with systemic steroids or even topical steroid also try to avoid those. But see, we learn with experience, and then probably subsequent cases, this experience will help us. But this was the first case we're dealing with, and we really did not have a clue what exactly we are heading to. And probably, yes, when you look back, steroid would have worsened. I agree. Yes, maybe.
Thank you. Yeah,
maybe steroids will increase the growth of the bacteria.
Agree. And particularly when they are resistant to drug, steroids will feed them up.
It's now the time is for, I have a question only before. Can you, Dr. Patricio, start, please? Dr. Patricio is a consultant ophthalmologist, head of ophthalmology department, Dubai Hospital, Dubai Health Authority, UAE. Before he start and he prepare his case, there is one question. Is there any role of anti-TB medication, Dr. Pramod?
Well, I don't think because non-tubercular Mycobacterium, there is hardly any role of anti-TB treatment. Generally, we do not. So regular conventional antibiotics are sufficient, adequate enough, because we know tubercular drugs are definitely, they are nothing but antibiotics, and they are extreme level of antibiotic and lot of side effects. And this non-tubercular Mycobacterium, generally they are rapid growing, and most of the time our conventional antibiotic treatment is adequate enough for them. We do not have to go to that level.
Thank you very much. Thanks a lot. Appreciate it. Now, Dr. My dear friend, Patricia.
Thank you so much, Dr. Alamri, for having me today, and thank you for sharing this time with my dearest colleagues, and also many thanks for all the people attending this video case presentation. Yeah, at the back is my own bookshare. It's nothing taken from internet. So I'm going to present a case of vitreous hemorrhage. This 30 years old healthy male was an officer in the army that was diagnosed as having vitreous and retinal hemorrhage and attends for a second opinion after 6 weeks of evolution. Nothing special, being in the army, having a head trauma some years ago, that's completely normal. No previous eye surgeries or any other eye treatments, and no family history. On examination, best corrected visual acuity was 0.15 in right eye and 100% in left eye. Anterior segment was completely normal in both eyes. Pressure was normal in both eyes. And at the fundus, we were able to see a small vitreous hemorrhage, some macular hemorrhages involving phobia, macular ring of exudates in the right eye, and for the left eye, 2 small spots of RPE thinning at the macula. You can see now the color picture here. You can see that.
Patricio, we cannot see yours.
Patricio, we cannot see your presentation. You are not moving slide to slide. Can you do us? Yeah.
I am.
We can't
you
see that. No.
You are still having only. Can you do stop sharing and go again, please?
Yeah.
Yeah, we are seeing only title slide.
Yeah, title. We see only the first. I was thinking that you are talking, introducing, then. Yes.
Can you see it now?
Yes.
Okay.
Yes.
So this is the color picture for the right eye. We can see at the macula some area of discolored hemorrhage. Here, I don't know if you see it, but there is some interretinal hemorrhages, a ring of exudates that come all over in the macula, something like aneurysms or hemorrhages here, not very clear view. So at this time, the differential diagnosis was maybe microaneurysms, maybe slivers, miliary aneurysms, choroidal neovascularization, BRVO, other forms of exudative retinopathy, eye trauma, etc. So we did an OCT, and for the right eye, we were able to see the hemorrhage. This thickness is more than it is shown here. I will show you later that this is something the Topcon machines are reading properly. The left eye was completely normal. We did an OCTA. There was not CMV. The vascular area seems to be normal. And then we did an OCTA through the area of one of the dilatations or hemorrhages, and we can actually see that there is flow. So it's not a hemorrhage, it's something like maybe a telangiectasia. We did a fluorescein angiography, and we can see that it is arteriolar, vascular dilatations. The veins are starting to fill in now. You see the enlarged vessels there, dilatations. For the white field, we can see that the dilatations are not only limited to the macula, we have some superotemporal vascular dilatations, inferotemporal, and nasal with some areas of capillary non-perfusion. Left eye was normal. This is a small area of RPE thinning here. And you can see that there is some leakage in the late frames of the fluorescein angiography. And you can see also very clearly the dilatations. So we thought it was miliary aneurysm. We were discussing with the patient the management. Observation alone, maybe intravitreal steroids, intravitreal anti-VEGF, past plana vitrectomy with hemorrhage or subretinal hemorrhage drainage, and maybe laser to the other areas which were asymptomatic at that time at the peripheral retina. So the patient didn't want to take any day off, and finally we decided on going for intravitreal anti-VEGF. I'm going to show you the OCT at presentation again, which is this one. And then after the first intravitreal injection, we can see that there is some intraretinal fluid. The thickness, as I said before, the Topcon machine is showing 309 microns. But if you actually come with a ruler, you see that it is 391. So it's not reading properly. It's thicker than it looks. We gave the patient a second injection. This is the before injections. This is after the first injection. And this is after the second injection. We can see that the retina has become thinner. The area of elevated retina is less and less. But there is some retinal thinning, some organization, and some scarring. So this is the outcome after 2 injections. Visual acuity did not improve. It was down from 0.15 to 0.10, but the macula seems to be more stable. Hemorrhages have disappeared, and the ring of exudates that extended literally in between the disc and the fovea has disappeared and stay smaller than before at the temporal part of the macula, and then there is this area of scarring at the center of the retina. This patient was lost to follow-up. We called him several times. Then soon after that, the coronavirus pandemic started, and we are trying to catch on him again. So the conclusions is there are very few cases reported. There is no trial for the assessment of a correct treatment for these miliary aneurysms. Most of them do not affect the macula. Anti-VEGF could be an option, but it is difficult to say if it is any different for a natural evolution, although I believe that the stabilization of the disease prevents further damage. And also for peripheral lesions, if there is active exudation or sometimes neovascularization has been described, laser can be an option. Thank you so much.
Thank you very much, Dr. Baticio. My question is, what is your diagnosis to give anti-VEGF?
Well, there was active hemorrhage. There was a discolored hemorrhage, subretinal, and then there was fresh hemorrhage, and the ring of exudates and the leakage at the late frames of the angiography. And the few cases reported in the literature, we have one presentation of 6 cases from Egypt, from Dr. Ahmed Abdelhadi, in which he showed a good result with aflibercept for this sort of cases.
Okay. Is there any question or comment from Dr. Carlos, Dr. Karina, or Pramod, Dr. Ayman, or question to Dr. Baticio?
I also have a similar doubt. Actually, yes, there's exudation. So till when angiograph was shown, until that time, I was looking at the typical picture of maybe retinal artery macroaneurysm. That's what my suspicion. And looking at the exudative ring and the central taut and dilated vessels, we could see. But when you have an angiography done and you see those multiple dilatations, then it changed the diagnosis. But with this diagnosis, again, I also, whether it's a natural course, hemorrhage got absorbed over a period of time, or whether anti-VEGF really helped, I'm not sure, because personally, I feel there may not be much role of anti-VEGF in this type of cases.
Yeah, I absolutely agree. As I said, we discussed all the chances, all the therapeutic options with the patient. What actually motivated me to go ahead with something is that he was an officer, active officer in the army, and it was the right eye, and he was not a left-handed person, so he really needed the visual acuity in the right eye.
Yeah, probably I would say it would have helped you, just exudation to clear, anti-VEGF would have helped. You get a better picture of angiography and supplement it with a focal laser treatment or something like that, because they are away from the foveal area.
Yeah.
Is that when you have these exudates accumulate under the fovea, you know, one of the risks is to have a fibrosis under the fovea, and then the visual prognosis is very poor. Then, you know, when these cases are late, and then perhaps you...
We lost your voice, Dr. Carlos.
Yeah. When you dry this, all of these exudates accumulate in the center. Then you have fluid, you don't have this accumulation. If you dry it, you have this accumulation. Then, you know...
Yeah, I agree. And we have the cases for Coats disease, where you have to remove the exudates, and you can go for a pars plana vitrectomy and remove. Maybe you will not improve vision, but you're going to stabilize disease.
Okay, is there any comments, any other comments? There is one question, Dr. Carlos, you are with me?
I'm with you, yeah.
Okay, Dr. Patricio, is this a case of FRAM? I don't know what's that, from Dr. Salem Al-Mutairi.
What is these letters? What are these letters standing for?
That's why I didn't know. Is this case of, I don't know if someone know about this abbreviation, FRAM?
No, I think these are kind of inflammation of the middle retina. I think it's not that.
Okay.
This is a typical case. Is a male, is unilateral, is relatively young. It's a typical case of a Leber's miliary aneurysm. I mean, it's not female, it's not 60 years old, it's unilateral. So it fits with the diagnosis of Leber's.
Okay, can we have the last question? Is there any role of focal laser directed on macular, I think, MA in such cases? If yes, could please share the parameters?
Yeah, I have treated not these Leber's in this case. I have treated macro aneurysms with focal laser. I don't burn the aneurysm. I go just peri-lesional until I get a whitish reaction. The power depends on the thickness of the retina, and that's something you have to titrate when you treat the patient. Every patient is different.
But if you imagine a case like this, and Pramod, for you also the question, imagine a case like this only with a macroaneurysm, and you have this fluid under the retina and some hemorrhage. How do you proceed with this? Not in a very fresh case, but you know, with this subfoveal, because I had one case, you know, 3 weeks ago, and I went there to remove the exudates. And how do you manage this?
Yeah, I try to be conservative until I see that the foveola is threatened, and then first step I usually go for gas. Then if I feel that the patient is not improving, because with gas sometimes you can get a good result, then I make a consultation to my vitreoretinal colleagues in the hospital, and we definitely treat the macroaneurysm and drain the hemorrhage. What's your take on this?
Okay. I think Doctor, this is a question from Dr. Shiva Kami. She's saying the FRM, familial retinal artery macroaneurysm syndrome.
I think that with the peripheral lesions we saw at the wide field fluorescein angiography, the area of ischemia, again, I feel that it fits more with Leber's by the patient's profile. and the absence of any other relative with any other affectation like this.
Okay, there is one last question. Could it be urban syndrome?
I doubt it.
So I think we get now to the end of, thank you, Dr. Batish, for this case. It's very interesting, something new, very rare. Thanks for sharing with us this case. Now we can have Dr. To present, dear colleagues and friends, Dr. Lilian Karina. She is an MD Associated Staff Physician, Eye Institute, Cleveland Clinic, Abu Dhabi, Clinical Assistant Professor of Ophthalmology, Cleveland Clinic, College of Medicine Case, Western Reserve University. So Dr. Karina, mic with you to present your case. Thank you very much.
Thank you so much. Thank you for the invitation. I'm learning a lot from this meeting. So let me share my own case. This is a case of, this is a non-surgical case, and I would like you to know my patient. The first time I met her was around March 2019. She is a 22 years old, so far healthy female, and she was referred to one of my colleagues in neuro-ophthalmology to assess that something was not good with her right optic disc. She has a long history of bilateral intermediate granulomatous idiopathic uveitis, and she has been treated by intravenous steroids and several doses of intravitreal anti-VEGF. Response to treatment was partial as per the reports she had with her. So she was advised to switch her treatment to the intravitreal dexamethasone implant. And also she wanted a second opinion from us about her case. So this is her very first ophthalmic evaluation with us. Visual acuity was normal, 2020-2025. IOP was normal and little bit low. No, both anterior segments were quiet with no keratic precipitate so far. 1+ vitritis in each eye. And let me show you how the fundus looked like. So the first thing you can see here is that the details are a little bit blurred because she had 1+ cells in the vitreous cavity. Also, there are some opacities in the vitreous. In the right eye, you can see here, and several in the left eye. And so she had a history of granulomatous uveitis, so maybe these were snowballs floating in the vitreous. You can see also that the optic discs are very hyperemic, and the right one, the borders are not well defined. And you can see here at the very far temporal and inferior periphery in the right eye, some fresh retinal hemorrhages. So we proceed with OCT of the optic disc, and although the machine is saying this is within normal limits, these discs are abnormal, are very elevated discs, mostly the right eye, but also the left one. If you see the OCT macula, this is the right eye. Again, the profile, it is preserved, but there is very important perifoveal thickening. And in this part, in the nasal aspect of the macula, you can see a little bit of neurosensorial detachment because something is going on with her right optic disc. Same for the left eye profile, it is preserved, but important perifoveal thickening, which is a sign of inflammation. Next step, we proceed with fluorescein angiography. And here you have in both eyes, widespread small vessels retinal vasculitis. In the right eye, I know it's not very easy to see in this picture, but see here how there is a very clear demarcation between the vascular and avascular area of the retina. So probably there is huge area of ischemia here. And you can see hyperfluorescence, late hyperfluorescence coming from the optic disc with leakage of fluorescein. And this is the hallmark for optic disc neovascularization. And this was why she was referred to assess the optic disc. So as she was diagnosed with granulomatous uveitis, my next step was an ICGA in order to assess the presence of granulomas at the level of the choroid, and both eyes were clear from granulomas. This is the right eye at 15 minutes. I'm sorry, because the left eye, it's at 9 minutes. And in order to rule them out, you should wait for the 14, 15 minutes frame. But trust me, there were no granulomas at the choroid. So we have a young female with bilateral intermediate granulomatous uveitis, complicated by retinal vasculitis and retinal neovascularization. Which are your differential diagnoses for this case? Can this be tuberculosis? Well, we know that tuberculosis is quite frequent in the area, and retinal vasculitis can be one of the manifestations of ocular tuberculosis, so it is possible. Can this be sarcoidosis, which is a kind of non-infectious counterpart for tuberculosis, but they share some clinical features, so it is another possibility. Or maybe our colleagues, they were right, and this is a case of idiopathic inflammation. So I asked for some blood tests, and everything was normal. Even the acute inflammatory markers, they were normal. Quantiferon was negative, so I ruled out tuberculosis with this, and AC and lysosine were normal. So with this clinical scenario, I proposed for her to start systemic treatment for her disease with a combination of systemic corticosteroids, oral prednisone 70 milligrams per day, which is around 1 milligram per kilo per day, according to her weight, mycophenolate mofetil 2 grams per day, and one more dose of intravitreal anti-VEGF in the right eye, because as you have seen, there was active optic disc neovascularization. She was in agreement, and we proceed with this. So, in April...
Can I interrupt you, Dr. Karina, here, please, if you don't mind?
Yep.
What is now your diagnosis to start this kind of medications? If you
but till here,
what you put in your mind?
Idiopathic.
Idiopathic.
Yeah, yeah. Okay. So in 1 month later, she comes back for monthly follow-up, and okay, the situation is a little bit better because you can see more clear details of the fundus because of the prednisone. So we have less vitreous inflammation, but still we have something in the vitreous here and something here. Still we have hyperemic optic disc, and still but of course we do not have any more the neovascularization, so no need for further intravitreal anti-VEGF treatment. So if you see 1 month later, the optic discs are still elevated. So it was not the neovascularization, there's something else besides. Both optic discs are still elevated, no changes at all in perifoveal thickening, and she was under 70 milligrams of prednisone, and same for the left eye. But okay, we said, let's give a chance to the treatment, let's keep the monthly follow-up, and she came in May, and everything was stable, not better. She was stable, she was the same, but she was not tolerating the prednisone, so we decided to tap her every 15 days instead of every month. In June, she was clinically stable, but not better. And when she comes for her follow-up in July, while on 20 milligrams per day of prednisone and same dose of mycophenolate, which is a very high dose, 2 grams per day, she has a relapse, okay? And this time, visual acuity was excellent, pressure was still low. Now she had cells in the anterior chamber, but no keratic. Excuse me? No keratic precipitates and no in either eye, and vitritis, a new vitritis. And what a surprise, her fundus. Now the fundus on 20 milligrams per day of prednisone, you have these white lesions here, mainly in the right eye, but also in the left eye, peripheral patches of retinitis. So now the clinical picture is completely different for this case. I proceed with a new fluorescein angiography, and we have still the presence of this widespread small vessels vasculitis. You have here these areas of enhanced fluorescein leakage. This is related to the areas of retinitis. And whenever you see something like this is called fern leaf pattern of retinal vasculitis. And the first differential diagnosis for this pattern of retinal vasculitis is actually Behçet disease, which is a non-granulomatous uveitis. So I asked her about the presence of oral apoptosis, and she said, yes, several times I had this problem in my life. I went from new blood test, and this time she had neutrophilia. And you know, Behçet disease is primarily driven by neutrophils at the very early stages of the disease. And finally, I asked for the HLA-B51, and she was positive. And although this is not part of the diagnostic criteria for Behçet disease, we know that having this marker positive increased the risk of the patient of having the disease. So now the most probable diagnosis was Behçet disease, and this is the 2018 update of the EULAR recommendation for the management of the disease, and it clearly says that in any patient with Behçet and inflammatory eye disease affecting the posterior segment of the eye should be on a treatment regimen such as azathioprine, cyclosporin A, interferon alpha, or monoclonal anti-TNF alpha antibodies. No one of these drugs were given to the patient. That's why she was kind of stable, but not improving. The only drug that was actually doing something for her was the prednisone. So which is the role of prednisone, of systemic glucocorticosteroids in Behçet disease? They should be used, but only in combination with azathioprine or other systemic immunosuppressives. But as you see here, there's no place for mycophenolate in Behçet disease. And this is the answer why she was not improving. So for those who are interested in Behçet disease, I recommend this nice chapter, which has been written by me and was published by the time I was dealing with her. So all the things I am describing is written here, and I was not seeing that in my own patient. So as I recommend in this chapter, I put her in oral azathioprine, and I started straightforward subcutaneous adalimumab for her. And I decided to continue tapering the prednisone because really she was dealing very bad with the corticosteroid. Usually in this kind of patients, you will increase your corticosteroid, but she was really not able to do that. After 3 months, of the proper treatment, this is how the fluorescein angiography looks like. So see only peripheral areas of small vessels vasculitis in both eyes, no signs of neovascularization. So even though we have a very ischemic peripheral retina, under proper management of inflammation, there's no stimulus for retinal neovascularization. See how nice are the optic discs now, are completely normal. And keep in mind that Behçet disease has central nervous system manifestations. So most probably these elevated discs were part of neuro-Behçet. We did for her MRI and everything, and there was no clear signs of neuro-Behçet, but this could be one of those signs. Macula, again, perfectly normal in both eyes. A very discrete epiretinal membrane here in the left eye, but her visual acuity is 20/20, and she's doing great, and we are just thinking about how to taper her systemic medication now. So, my take-home messages from my case. First of all, always question your own diagnosis as well as the one of the others, because all the features of Behçet disease were present at the very first slides I show you, but I was somehow driven by her report. Try always to reach an etiologic diagnosis and treat accordingly. Your results are going to be better if you know which disease you are treating, because not all immunosuppressants are good for any kind of inflammation. If you do not have a clear response to treatment, you might be doing something wrong. Don't think that all diseases are very difficult to treat and all your cases are difficult. Maybe you are not doing the right treatment for your patient. Always talk to them, because I told you at the very beginning, she was a healthy lady, but I haven't asked her about oral apoptosis. So if I do not ask, she probably will never report this to me. And keep in mind that you will not find those things that you are actually not looking for. And then finally, do not allow a single tree to hide the whole beauty of the forest. Thank you so much, and I am happy to answer your questions.
Thank you very much, Dr. Karina, for a very interesting case. Actually, we have several comments I have to deliver or to mention to you. Now we already diagnosed the case. There is some suggestion maybe it is an MS case. I think this one not anymore. There is one very important. There is one he say, Dr. Muhammad Hamad. There is no sign of granulomatous uveitis. He mentioned that at the early he was not seeing any granulomatous there. And he said there is also another Dr. Salam Notari. We need to do MRI to rule out any other things. Very, very important comments. Dr. Shiva, she said, maybe her, Dr. Shiva from Dubai, and she's saying that Behjat disease. This is her diagnosis even before you mentioned. So I want just to mention this one for you. And granulomatous uveitis is not associated with Behjat, and this is well known.
Granulomatous disease, but then let me share my screen once again. So I agree, Behjat is a non-granulomatous uveitis, but wait a minute. Because there was something in one of my first slides that I thought someone was about to ask me what was that. Well, I cannot share, I don't know why, but the question is why you had those things in the vitreous at the very beginning. So what is this? Well, here we have the retinitis. But at the very beginning, when I show you the pictures and I said this might be snowballs, well, they are not, because where do you see the snowballs? The snowballs are at the bottom of the eye. And here you have things floating, see? So what is this in this patient? Some cases of Behjat disease, they have like a cumulus of cells in front of lesions in the retina or in the vessels. But if you take this sample of vitreous, these are non-granulomatous lesions. So it's different from granulomatous uveitis and snowballs formation. It's histopathologically different. Yeah, of course, this is not
a comment. They are saying this is called this is a retinitis, not actually like a granuloma.
No. These are no. This is in the vitreous. Here is in the vitreous, so it's not in the retina. But when she relapsed, this was a clear area of retinitis. If this area is like close to the retina, to the macula, excuse me, usually you admit the patient and you start intravenous treatment. I decided to follow her up because this was very peripheral and she responded, and we were very lucky because we got the adalimumab very, very fast and she responded excellent. In the first dose of adalimumab, this disappeared, but these were clear areas of retinitis, yeah.
Okay, thank you very much, Dr. Karina. Just can you stop share the slide so we can have a group discussion? I have one question for you. Why do you use anti-VEGF in the beginning when you are saying it is an idiopathic uveitis?
Because the treatment with anti-VEGF was aimed to target one complication of the inflammation, which was the active optic disc neovascularization. Once you have the inflammation under control, you will not have further stimulus to develop neovascularization, but you have to treat this neovascularization.
It could be treated by steroid rather than anti-VEGF as a part of treatment of uveitis if you think it's autoimmune.
You mean using intravitreal steroids?
Yeah.
The problem is that you do not have a clear diagnosis and you will add probably cataract. So once the patient develops cataract, it will be even more difficult for you to reach a diagnosis.
Okay. Is there any question to Dr. Karina?
Can I ask Dr. Karina a question? Karina, thank you very much. This is really a very interesting case, and this is the first time I can see clearly the front leaf appearance in cases of Behçet disease, which is really interesting. My question, we know that Behçet is a pan-uveitis, usually, and in most of cases we see an anterior chamber and an anterovitreous reaction. How frequent do you see just a posterior segment involvement in Behçet disease without anterior segment involvement?
Here, I can say that I have seen Behçet disease in my own country, in Argentina. I have seen them in France and now here. And of course, we always test the same HLA-B51 and it's positive all around the world, but I am not sure if the phenotype of the disease is the same in different races. Having said that, I can say that here it's very common to have only vasculitis. I can remember my few patients with the hypopion and with the cells and whatever, and all the pan-uveitis of Behçet. Here, mostly it is a retinitis, a severe retinitis, and of course, occlusive retinitis with areas of ischemia and with the neovascularization, but mostly it's vasculitis more than retinitis.
Thank you, Karina. Very interesting.
Okay, Dr. Batisho, yes, can you just unmute yourself, please?
Yeah, thank you very much for this very nice presentation, Karina. Do you have a step-ladder approach for the use of immunosuppressants, or you just jump directly into the biologicals when you see Behçet's affecting only the eye?
Depends on the diagnosis, because for some diseases like Behçet disease or HLA-B27 disease affecting the posterior segment of the eye, we know that they respond very well to the anti-TNF. So if the diagnosis is clear, if there is posterior segment affection, why not? I mean, they respond very well. So the answer will be depends on your diagnosis. But this is one of the most clear indication for anti-VEGF. And for that, you have all the recommendations from the EULAR group.
Okay, Dr. Karina, we have another 2 questions. We want just a very short answer, so we are running behind the time. It was an excellent talk. From Dr. Salim Al-Mutairi, posterior uveitis of Behçet is better to treat with, this is his comment, with anti-TNF, but anterior uveitis, so immunosuppressive can work. What is your comment about?
Anterior uveitis? Well, if anterior uveitis is very recurrent and you have already ruled out the posterior involvement, I mean, there's a normal fluorescein angiography, and the anterior uveitis is recurrent and you need to put the patient on topical steroids very frequently, maybe you will need another immunosuppressant systemically because you will have side effects from the topical steroids. Then you are not supposed to go for anti-TNF in Behçet if your involvement is only anterior, but why not azathioprine? Azathioprine is well known to have excellent effect on Behçet disease.
Okay, maybe it will be the last question for you, if it is for you, I think, this one. Did you consider laser to the low perfusion area? You can hear me, Dr. Karina? Hello?
Yeah, I'm sorry, I completely lost the connection.
Okay, I thought I am the one who lost connection. Okay, so the question is, do you consider laser to the low perfusion area?
Well, this is a very interesting question because I am not sure about the answer. What I can say is that in my experience, if the patient is well treated for the inflammation, you follow them over the time, and if inflammation is quiet, these patients, they do not develop retinal neovascularization. So I would say that if inflammation is under control, probably there's no stimulus for neovascularization, so you can observe. Because in these cases, this is a very inflammatory disease, you might even do worse with the laser. You can even trigger more local inflammation.
Okay. How do you explain the decrease in neovascular after starting azithromycin treatment?
Well, I did not start only azathioprine. She was in a combination of azathioprine plus anti-TNF. So this is what I was expected from her. And I wanted to show you how fast she improved once she had the proper treatment.
I think by this we cover most of our questions, and there is one only question. I don't know if someone answered or not. This one is not for Dr. Karina. This one, I think, for Dr. Pramod. It is difficult to see retina or choroidal details in silicone oil field eye during ultrasound. Any comments?
Yeah, basically you need experience. I agree with that because of like a sound wave velocity changes. With the experience, you can have a different maybe velocity you can use. You can use maybe orbital mode if necessary. And with the experience, you can reasonably detect. Yes, it is difficult, and particularly emulsified oil is there is become much more difficult. Also a little bit oblique. If you go ahead, as you see this scan you saw in a presentation, we could get a very good picture with the silicone oil inside the eye. But yes, I agree with the question. It's not that easy.
Thank you very much, Dr. Pramod. Is there any comment or anything from any of our panelists here before we can conclude these sessions? It was an excellent, very interesting, very difficult cases, interesting cases, mystery cases, good presentation, good speakers and eminent speakers. Dr. Carlos, Dr. Ayman, Dr. Karina, Dr. Pramod, or Dr. Patricio, any word before we move?
I would say thank you very much. Excellent discussion, and I learned a lot of multiple cases we had with a lot of variations. I think it's an amazing meeting. Really enjoyed. Thank you very much.
Thank you, Dr. Pramod. Thank you.
And nice to get introduced with all new people, and probably we will be in touch. I think we'll continue our interaction future.
In another webinars, or we can meet you unlike if the situation goes and the coronavirus we get rid of it.
Post corona, if you travel, yes, we will make a point to meet.
Thank you very much. Thank you, Dr. Carlos. Thank you, Dr. Ayman. Thank you, Dr. Patricio, Dr. Karina. And I would like also to thank Bayer for supporting this meeting. And also I would like to thank Marvision for managing this event. And there is one question, I don't know, regards of the Argentina of the presentation. We are all excellent. Okay. This is one thanks from Doctora from Argentina. He's Karina Julian, I think. Okay.
Yes, thank you so much for those who are connected from Argentina. Thank you.
Okay. That's why I get a message from Argentina today or an email. So you are the one behind that. Thank you very much.
I am promoting you. Yeah.
Thanks a lot.
Thank you very much. Thank you.
Thank you. Thank you.
Bye-bye.
Thank you, everybody. Good night.
Have a wonderful week ahead.
Thank you.
And stay safe.
A la vista, Carlos.
Bye-bye. Thank you.
Bye-bye.
Bye-bye. See you.
Bye.